Hello. Today's question for what I want to know comes to us from Brenda, who writes the following. I've met a plastic surgeon that I like, and we've discussed contouring my belly with liposuction. However, he says that he uses standard technique and does not employ ultrasound or other mechanisms. I'm concerned about that and wonder what you think. Should I be having ultrasonic or laser? He seems nice and comes highly recommended, but I'm worried he might be behind the times, and I'm really confused. Well, given the number of devices, technologies, and advertisements out there, I can understand why Brenda would be confused. And so I chose this as a topic worth considering here. I think that there is widespread confusion about these things, and it's best that we try and deal with it. Liposuction, of course, is a very widely used surgical technique for performing surgical lipectomy. It's minimally invasive, meaning we can remove broad areas of fat, reduce their thickness through tiny incisions in the skin. Developed in the late 1970s and largely brought to this country in the early 80s, liposuction has become very widely practiced, and in fact is practiced by non-plastic surgeons on a reasonably widespread basis. Now, what's appealing about it, of course, is that we can make these changes to body shape in well-selected patients without leaving substantial scarring on the body. The incisions we typically make today are a few millimeters in size. In the early days of liposuction, because our cannulas were larger, we made larger incisions. But the important point is there are no long cuts in these procedures. Now, just as minimal scarring is the advantage of liposuction, liposuction has an important limitation. Since we're not going to be cutting the skin and tightening it as surgeons, the skin has to take care of that on its own. And so one of the important things we have to assess in a patient preoperatively is, do we think the skin is able to shrink back and take on a uniform, smooth contour, or has it lost its elasticity to the extent that that's unlikely? This is something the surgeon has to evaluate and the patient has to take into account in his or her decision-making about surgery. Now, the original liposuction technique, as practiced in the early 70s or late 70s, I should say, and early 80s, was a strict mechanical process. The surgeon uses a long, thin metal tube called a cannula and pushes that into the soft tissues, into the fat, with the mechanical action of his or her arm. And then that process, together with suction being applied to the cannula by an external pump, disrupts the fat and evacuates it. This mechanical process remains the basis of virtually all liposuction techniques today. Now, you're going to hear about, and perhaps already have heard about, things like the use of ultrasound or power assistance or laser technologies and so forth in liposuction. And we'll consider today the application of these, why they're used, and what we know about their use in body contouring. But I think it's important to point out that the data do not at this point indicate that any of these technologies provides a specific advantage or leads to superior outcomes. We'll return to that after we discuss these various techniques.
In liposuction, do the technical choices of the surgeon matter to the patient's outcome? All of the technologies employed in liposuction are meant to assist the surgeon in the minimally invasive removal of fat. The standard by which all are judged is suction-assisted lipolysis, or SAL. Here, a thin metal cannula is propelled through the fat by the surgeon's arm movements. This provides for the mechanical disruption of fat, and the fat is aspirated from the wound by a vacuum pump. This has a long history of successful use. The instrumentation is simple and inexpensive, and it avoids risks that may be associated with non-mechanical energy forms. the surgeon does work harder, and there's a greater challenge in extracting fat from fibrous collections. As a result, greater force needs to be delivered to the cannula, and this may risk injury to the patient. With power-assisted lipolysis, or PAL, there is also the use of a thin metal cannula propelled by the surgeon's arm, but this is assisted by a reciprocating engine. This also provides for mechanical disruption of fat, and the fat is aspirated from the wound by a vacuum pump. This is easier on the surgeon and provides improved control. The instrumentation, though more expensive than for standard liposuction, is relatively inexpensive. It avoids the risk associated with non-mechanical energy forms, and the fatty extraction from fibrous areas is facilitated. However, it is slightly more complex, and the instrumentation slightly more expensive. Ultrasound-assisted lipolysis, or UAL, employs an ultrasound probe to emulsify fat. This is inserted beneath the skin as the first step. A cannula is then inserted after the fat has been emulsified, and the fat is aspirated from the wound by a vacuum pump. An example of this is called vaser. This technique facilitates fat removal from fibrous areas and diminishes the work of the surgeon. It avoids the need for higher mechanical forces in SAL. However, it has a higher rate of seromas, or serous fluid collections, beneath the skin. As a result of this, some surgeons will place drains after the procedure is completed. There is a risk for burn from the piezoelectric ultrasound probe, and the equipment is more complex and much more expensive. The incisions used will need to be larger in order to protect the patient from burns. External ultrasound-assisted lipolysis, or EUAL, allows for delivery of ultrasound energy through the skin. A cannula is inserted thereafter, and the fat aspirated from the wound with a vacuum pump. This may facilitate fat removal in fibrous areas and diminish the work of the surgeon. It may also avoid need for the high mechanical forces of SAL. However, there is a greater expense for this equipment, and there's poor evidence of effectiveness. As a result, it is not widely used. Laser-assisted lipolysis, sometimes referred to as LAL. Here, a laser probe is used to disrupt fat cells with laser light. A cannula is inserted after emulsification of the fat by the laser, and the fat evacuated by a vacuum pump. Examples are called smart lipo or slim lipo. This facilitates the fat removal if the areas are fibrously surrounded, and diminishes work for the surgeon. It also avoids the need for higher mechanical forces in standard liposuction. There is question as to whether it reduces bruising, although this has been suggested. Downsides include the need for laser precautions. There's a risk for burns, and the equipment is more expensive and complex. Other technologies exist, including twin cannula lipolysis, or TCL, and water-assisted lipolysis, WAL. These are not widely used. All technologies assist in fat disruption by using different energy forms. This leads to lower mechanical energy needed from the surgeon and make extraction from difficult fibrous areas easier. They may provide for more refined control of the instruments by the surgeon. What they most importantly do is help surgeons deliver what they believe to be good results. Claims regarding individual superiority are unfounded, and in fact are marketing. The result seen here is one achieved in lipoabdominoplasty, an operation involving liposuction of the entire abdomen with a tightening of skin and minimal undermining. This particular result was achieved using power-assisted liposuction, but might equally have been achieved using any of the technologies described.
So finally, getting back to Brenda's question, should she be concerned that her surgeon is behind the times somehow because of his choice of liposuction technique? Well, I think clearly the answer is no. I personally choose to use power assist liposuction in my cases, and I have reason to believe that it provides me some greater control of the instrumentation. But I can't and won't say to any of my patients that they'll necessarily get a better result because I'm using that. I think it's fair to say that no surgeon should claim to the patient that ultrasound or that laser will provide better results, because there really isn't any data to suggest that they do. Surgeons have their reasons that they can certainly share with patients for a choice of a particular technology, and each surgeon presumably comes to the belief that that particular technology is advantaging him in some way. But I think he or she needs to be very careful to suggest to patients that that somehow inevitably leads to better outcomes. As I've said, the science doesn't provide us that as a conclusion. I personally know and respect a great number of surgeons who use a variety of these techniques, some who are great practitioners of ultrasound, others who use straight mechanical liposuction, and others who, like myself, prefer power assist. The important thing, I think, is who's on the other end of the cannula, if you will. Not so much what technique does he or she use, but what experience does he or she bring to the process, what judgments, what skill. This is how I would advise patients to decide about liposuction surgery, not so much the technique, but the practitioner.